Participants are in a listen-only mode. After the presentation, we will conduct a question-and-answer session. To ask a question, please press star then 1 on your touch-tone phone. You will be prompted to record your first and last name. Today's conference is being recorded. If there are any objections, you may disconnect at this time. I'd now like to turn the conference over to your host, Dr. Stefan Baral. Thank you. You may begin.
Thank you very much. Good morning, everybody, and good morning, everybody online. I understand we have quite a bit of participation online this morning, and I'm not surprised. I would like to welcome you all to the third 2015 Centers for Disease Control, Division of STD Prevention, and American Sexually Transmitted Disease Association Prevention Science Series session. It gives me tremendous pleasure this morning to introduce to you Dr. Stefan Baral, who is quite an expert when it comes to key populations globally. Stefan got his training in Canada. He is currently an associate professor at the School of Public Health at the Johns Hopkins University. It's Bloomberg School of Public Health, right? And he has been doing a lot of work on key populations in Central and Western Africa, in Eastern and Southern Africa, on HIV mostly, which is an STD, as we all know. So I first came across Stefan's work because I was reading sex worker-related stuff. And with the first paper I read, I was completely impressed. And then I sought him out at meetings and did a little bit of Google listening to the talks he has given in different places that have been recorded. I think you're going to agree with me that we have a wonderful hour ahead of us today to listening to him. I would also like to invite all of you to the panel discussion we have organized for this afternoon, which is going to include Dr. Stefan Baral, Dr. Gabriela Paz-Bailey, Dr. Kyle Bernstein, and Dr. Patrick Sullivan of Emory University. It will be moderated by Dr. Gail Boland. I think it's going to be another intellectual feast. So see you there as well. Stefan, it's all yours.
And so thanks so much to Stefan for inviting me. It's really an honor to be here. So when invited to the CDC, I wanted to share as much data as I could in the short time that I have. So I'm going to talk both about MSM, so gay men, other men who have sex with men, and then trans women separately. And I'll talk about some systematic reviews that we've done updating our knowledge about burdens of disease. And so then I'll talk about what we know about levels of HIV risk, so individual levels of risk and then higher order levels of risk, including structural determinants. I'll present some data that we know about how people are engaging in the continuum of care, and basically what we know as to some of the facilitators and barriers to people's success in that. And I think some emerging challenges that we're seeing with some of the new prevention and treatment strategies that we see. And I'll do that in an hour. So, I want to start by providing a slide that maybe some of you have seen before, but it's basically a systematic review that we had done looking at the HIV prevalence among men who have sex with men internationally. And the one piece that I want to point out here is just the remarkable consistency of the epidemic among gay men and other men who have sex with men internationally. So whether we're looking at North America, Central and South America, Sub-Saharan Africa, South and Southeast Asia, you see somewhere between 16 to 18% of all MSM to be living with HIV. And I think this message sort of underpins one of my themes throughout this talk is that the world is probably more similar than it is different in terms of these epidemics, both among HIV and STIs amongst these men. So the region in which I work, or the continent where I work, is Sub-Saharan Africa. And going back about 10 years, we had very limited data from across the continent. We have these sort of 4 distinct HIV epidemics across Sub-Saharan Africa. In Southern Africa, you have these broadly generalized epidemics. In Eastern Africa, you have slightly more concentrated epidemics with prevalence in the range of 6 to 7% in the general population. Western Africa, you get to more concentrated epidemics with 1 to 3% general population prevalence. And then North Africa, you have very concentrated epidemics that look more like Europe or Latin America. But in all of these settings, and going back 10 years, we had very sort of disparate data among MSM. But what we saw was, again, this consistency of a high burden that was dislinked to the epidemics going on in the background. And so that you could have significant epidemics among MSM where you don't have epidemics in the sort of average risk reproductive age adult. So in Southern Africa, Eastern, Western, Northern Africa, we saw high and consistent prevalence. And basically over the last 10 years, we've continued filling in the map. And what you see again in these places is just that there's more consistency than there are differences in terms of prevalence. And really where we don't have data from some countries in Central Africa, some countries in Northwestern Africa, are really it's an issue of safety. There's community groups there, there's gay men, other MSM there. It's just an issue of safety both for participants and staff in terms of doing the work. In terms of incidence data, obviously it's far more limited. These are all based on prospective cohorts. There's no ability to do cross-sectional incidence from these populations. But what we see are very high incidence rates. In our cohorts in Senegal and Nigeria, we've had double-digit incidence rates over a couple years. In Kenya, depending on where in Kenya, coastal or inner Kenya, they've seen between 7 to 20% incidence. Similarly, in Uganda, Malawi, and South Africa, high and sustained incidence. And while many people feel that these are new epidemics, that the data are older in North America and high-income settings, in fact, from coastal Kenya, this is work that's supported by IAVI and done by Edward Sanders, they've had a cohort of MSM for about 10 years, and they've seen sustained incidence in that time between 7 to 10%. And so these aren't new epidemics. We're starting to study these men, but they've been around, and risk factors have been around, obviously for some time. And I think that the sort of incidence that we're seeing in Kenya, although a little bit higher, is consistent with other parts of the world. This is also based on that systematic review that we did a couple years ago and tried to update last year, where we basically looked at incidence among MSM around the world. And the reason we did this is that, if you look for the people who pay attention to HIV in the room, the cover of The Economist a couple years ago with 052 was that basically HIV was over. And we've seen these really wonderful declines in general population prevalence and even incidence in many settings. But when you look at incidence among MSM, I think as this room knows well, we've not seen those sort of declines in incidence. There's been about 2 to 5% incidence in most countries around the world, and the places where we have better data, we actually see incidence increasing in many parts of the world. And so there are a few examples now of declining incidence in San Francisco, for example, but those are few and far between, and the majority of places have sustained an increasing incidence in the context of a slowing global epidemic or pandemic. And then another element that we found is that in many of the places in which I work, when we look at the molecular epi of HIV, people have been, felt that these epidemics are happening in a way that is not linked to what is happening in the sort of the general population, that the strains among men would all be B-clade, all from Europe, all from North America, and that it would be different than the predominant clades that you see amongst other people. And in fact, when we've looked at this just hasn't been the case. And the most obvious example is South Africa. So South Africa has a heavy B-clade predominant epidemic. And while there's some B-clade predominance in the midst of cities like Cape Town and Joburg, as soon as you get out into townships, it's 95% B-clade among MSM, as it is amongst other populations as well. Similarly, in Senegal, Kenya, which is known to have more of a mixed epidemic, you see that same trend. So, it's not, the idea here was that, you could ignore populations of MSM and that it would sort of settle itself, when in fact, you see this overlap of the actual strains and clades of epidemics. In Asia, we've seen this really interesting increase in the Thai AE recombinant that used to see only in Bangkok. Now in studies in China and Singapore, you're seeing more of this Thai AE recombinant, and so it gives us insight of how we can use these molecular epidemiologic tools to understand how transmission is happening, and an interesting tool. Another, sort of common trend that we have, and just sort of an emerging issue that I think many in this room are familiar with, is just the importance of adolescent and young gay men. Now, in many settings in which I work, these are data from across Africa. What you're looking at is basically we can't do studies of MSM under the age of 18. We can barely do studies of men over the age of 18. But, the idea of doing studies with youth is particularly problematic. So we asked this retrospectively. And what you see across the board is what you'd expect, that most of these men had sex before the age of 18. And so they've had a number of acquisition risks before they reach the age of 18 when no programs or no services are reaching them. So these are data from across West Africa moving into Southern Africa. These are data from Ken Mayer that were shared with me by Ken Mayer and his group at IMPACTA with Jorge Sanchez and others in Lima. But what you're looking at in the maroon in the middle is the HIV prevalence, and in the sort of darker color, the first one is syphilis prevalence. And so while they don't have it split up between under 18 and between 18 to 25, what you see is that by the time these gentlemen are 25, when they're starting to engage more in programs, you already have 12% prevalence in this group, and that goes quickly up to 18%. And so again, it's just that message of, we're doing very little in this day and age for adolescents, for the 15, 19-year-old and even younger, and clearly that's an issue. And Patrick Sullivan shared these data with me from his Involve MENt Cohort here in Atlanta, focused on both black and white MSM. And while they had, again, 8% prevalence among those 18, or 10.4% amongst those 18, 19 among African-American MSM, about 6% among white, it jumps dramatically to 34% prevalence amongst those 20 and 24. And so, this is the sort of one population where prevention really is key, right? That prevention is not just treatment programs, but prevention programs actually have the opportunity to reduce incidence and change the trajectory of the epidemic. And we're writ large, both internationally and as well in domestic settings, not doing a good job of preventing those initial acquisition events amongst young men. So moving on to transgender health research. So there's an upcoming special issue of The Lancet and I was part of the global burden of disease paper led by Sari Reisner, who's now at Harvard, was at Fenway. And so, we did this systematic review. In the end, we found about 116 studies that characterized transgender health broadly. And so I thought I'd just sort of run through about a few things about what we found interesting about some of the characteristics of that. So this is a map of the world, and in sort of a lime green, you see where one study had been done looking at any sort of trans populations. And so Mexico, Norway, South Africa, Chile. And then you have where 2 to 5 studies have been done. And this is going back 15 years, so where 2 to 5 studies have been done. So my own Canada, 2 to 5 studies, a few countries in South America, a few countries in South Asia. And then in the United States, it's not an error. I would point out that it's 60-plus studies. So really, the majority of data and the majority of understanding that we have about transgender health broadly, whether it be trans men or women, really comes from the United States. And so that's wonderful for the U.S. in terms of understanding some of the issues here. It also challenges about what we know in other places. And this is from another paper in that series, from Sam Winter's paper, where they looked at basically the prevalence of transgender people in a population. And the first studies from the U.S. and the studies from UK and New Zealand and Europe. But what you see is that there's actually, again, there's a consistency in the prevalence of transgender people where studied. And it's somewhere between 0.5% to 0.8% of people are transgender. So it's not that the U.S. has far more trans people than anywhere else, but there has been far more of an investment into trans health research and trans health outcomes research in the United States than other settings. But I think it's really a message to other parts of the world that we need to catch up in many ways and understand more about the specific needs. Another element, so I'm going to focus today on trans women. This is a slide looking at basically transgender health research side, the sex assigned at birth. And the reason that I'll talk about trans women is not only because that's where we have our best data, but if out of 116 studies, only 9 of them, so less than 10% focused on people who were assigned the female sex at birth exclusively, so on trans men. And the vast majority, more than 90%, focused on trans women or people assigned the male sex at birth. So again, we will focus the talk on trans women, but there's also clearly that's where the majority of work has been done. And it does speak to the need to better understand the needs of trans men sort of writ large for a number of different outcomes. And there's some emerging work, I won't talk about it today, but about cervical cancer and other really, I think, interesting elements that are just emerging. When we look at the average HIV prevalence among trans women by region, again, we have more data from North America, and you see we don't have error bars here, but you see about 20, 23% prevalence, a little bit higher in Central South America. You see higher burdens in Europe, but this is, a limited work, mostly done in the context of STI clinics And so it's not unexpected that you're selecting for a higher burden population. And then no data from sub-Saharan Africa. And this is from here again is a map of the world, and it's from a systematic review that we did a couple of years ago looking at the burden of HIV specifically among trans women. And, what we found was we had done a number of these reviews to try and understand sort of, how HIV was evolving, the epidemic as a whole was evolving. And what you see among trans women, we had data from 15 countries, so it's a very limited data set. But amongst all the populations that we looked at, whether it be prisoners or female sex workers or MSM or people who use drugs, the highest disproportionate burden of HIV was among trans women. So again, it's a message of limited data, but clearly a very high burden of HIV amongst these women. And then also in white is where there had been no studies going back 15 years. And so, basically the whole continent, again, of Africa, all of the former Soviet Union, large parts of Eastern Europe, Central Asia, really there had been no work done. So I think a message for the need to do more. In all our studies of MSM across Sub-Saharan Africa, we do a two-step gender assessment that was developed by the Center of Excellence of Transgender Health at University of California, San Francisco, and Joanna Keatley's group. And it's a simple system. It's basically what sex were you assigned at birth and what sex or gender do you identify as now. And when we do that, again, these are people who've come in for a study for MSM, but we see, 16% in Burkina, nearly 20% in Malawi, quarter of the sample in Swaziland, have identified as not their gender of birth. And that, by the way, is consistent. We now have more data. And you consistently see between 15 to 20% of MSM that are, I should say, of people who've been accrued for a study for MSM that are not identifying as men. And I think important. In Swaziland and Lesotho, this was independently associated with prevalent HIV infections. And the last thing I'll say about trans health is that there's really an encouraging trend. When we looked at the number of studies by year, you can see sort of a consistency of about 10 publications writ large for any trans populations around the world from 2009 to 2012. And then since then, we've seen a rapid increase in the amount of trans health research. So hopefully this means that we'll continue to know more as the years go on. So moving on to sort of levels of HIV risk. So, I think we developed this model based on socio-ecological models a few years ago, but it basically helped us frame what we understood to be individual level determinants, which are clearly important, biological, behavioral determinants that either potentiate or mitigate HIV risk. But we found that there had been a lot of rhetoric about higher order risk factors like sexual networks, larger sexual networks, non-dense sexual networks in terms of potentiating HIV risk, the value of social networks in terms of mitigating HIV risk, in terms of being protective, community-level determinants in terms of stigma in your community or access to services within your own community, the importance of public policies in general, like don't ask, don't tell, or criminalization in other settings. But so we did we did another systematic review that we published in JAIDS last year, where we wanted to ask this question of, so there's clearly more rhetoric around structural determinants of health, but where have people actually been including these determinants in studies of HIV? So we looked, we basically looked at all our HIV studies again, and we just asked the question, in low and middle income countries specifically, where had people included even a single structural determinant of health? Because as I showed you, we had lots of prevalence data, incidence data, condom use data, and I think what was telling here in light blue, you can see the places that included even a single study with MSM. And so you have some data from Brazil, from South Africa, from Uganda, from actually a CDC-funded study there, and Senegal, and some from India. Among trans women, there was a single study, and it was just basically where trans women had been included in a population of male sex workers in India. So again, there's just a clear disconnect between what people appreciate as the importance of structural determinants, but the actual investment in measuring those determinants as part of any HIV study. So another clear individual level determinant are STIs. And so I want to present some STI data from the work that we've been doing. So we have a cohort together with the University of Maryland and the MHRP in Nigeria in 2 sites, in Lagos and Abuja. And so these are Lagos data where we measured the prevalence and, high prevalence of gonorrhea, chlamydia, syphilis, and all of these men, when asked, were reported as these being asymptomatic. Similarly, in South Africa, these are data from Kevin Reeby and James McIntyre's group in Cape Town and Johannesburg, where, again, they measured gonorrhea, chlamydia, and dual infections separately and found, again, that the majority, as we know, are asymptomatic. The issue in these settings is that they rely almost completely on syndromic surveillance, right? And so, what we recognize in these settings is that, most of these, except in the context of sort of research studies, are going undiagnosed and untreated. These are data from the U.S., and, again, I turned to this from Ken Maier's group in Fenway, and it shows a trend that, people in this room I think are very familiar with about these increasing burdens of STIs among MSM. And the reality is that we're only starting to measure it in the last few years internationally, but we see similar trends. We just don't have the baseline to work off of. And the same issue that they're seeing in the U.S., these are down age data, but, is that even in the context of HIV clinics, while syphilis was effectively screened for, 60 to 75% of gay men or MSM living with HIV across these 8 clinics have been screened for syphilis. Few have been screened for gonorrhea and chlamydia. And again, these are men living with HIV in the context of HIV clinics. And so we couldn't find more recent data than this. I'm sure there is, but it's sort of hopefully that over the last number of years there's been an increase in the amount of screening, especially for MSM living with HIV. So another key determinant that we know to be important is the use of the internet, right? I think that, across the United States of many high-income settings, we've started using the internet, obviously, for surveillance. We started trying to use the internet better for prevention approaches. We as well want to measure the use of the internet to find sexual partners in work led by Shauna Stallman, who's here today, to try and, again, see, is there sort of, because these are lower income settings, are people not using the internet? And the fact is that, as I think we expected, there's a very common use of the internet and newer apps to find sexual partners in a number of settings. And so these are data from Lesotho and Swaziland and countries in West Africa and Namibia, Botswana, also South Africa, but common use of the internet. And you see a little bit more in some places amongst younger MSM, but in fact, often you're seeing high use of the internet both among young and older MSM. So I'll just give some more in-depth analysis on Lesotho and Swaziland. So just for reference, these are 2 mountain kingdoms that are one, Lesotho is completely within South Africa, Swaziland is just between South Africa and Mozambique, but 2 sort of small kingdoms. And so we did studies there of MSM, and we wanted to try and understand the determinants of the use of the internet amongst these men. And I think what we found was really interesting, that the men who were turning to the internet were basically men that were experiencing more stigma and fear in their everyday lives. And so, that is not an uncommon trend that we've seen in other places, that when people are unable to meet partners in physical venues, they're turning to the internet to use, to find partners. The challenge there within is that these men are also much more likely in independent analyses to test positive for HIV. And so, those risks have been well characterized in a lot of places, that you're less likely to know the status of partners that you meet online. You're less likely to know their backgrounds. Potentially when you meet, you're less likely to use prevention commodities. And so, again, just that same trend of the importance of the internet in terms of the risks for people, but also clearly as a tool that we should be using to engage people in really around the world. And we've also found, that mental health has been one of these issues. I mean, mental health has been sort of dramatically underexplored across the African continent for writ large. We've been using in our surveys over the last number of years the PHQ-9. There's a number of options of ones we could have used. We landed on the PHQ-9 to define basically as a depression screener. And what we found when we do this, first of all, is that depression is remarkably common, that we're seeing about half our samples test positive for depression, which is again, as I'll show, is a trend that is not distinct, obviously, to the African setting or to high-income settings. What we don't have is anything to reference it against the general population, because our estimation is likely that there's a fair amount of depression and mental health issues in the general population across the continent that just really has gone unmeasured. But what we also saw here is just the significant relationship between testing positive for depression in independent analyses and syphilis. And so, and it's strong that people who tested positive for depression were almost 3 times as likely to have active syphilis infection when we tested it as part of our study. And in the unadjusted analyses with HIV, although that association fell out in the independent analyses. So when we looked at sort of the determinants of depression, and this is work that builds on work that's been done in the United States to try and understand. So clearly there's minority stress that's happening, specifically for gay men around sexual orientation, probably even more so for trans women around sexual orientation, gender identity. But what we saw was very significant relationships. This paper is now out I think in AIDS and Behavior, but basically seeing this strong positive relationship between people's experienced stigma in their lives and having a positive PHQ-9. And so, and then the corollary is that we also see a really strong inverse relationship with higher social capital. So when we measure social capital in terms of social inclusion, social cohesion, and social participation, if they have higher social capital, they're much less likely to test positive for depression. And so I think there's a few dynamics here. One, the importance of stigma interventions in terms of acting as an antecedent to depression and some of the STD outcomes, but also the building of, potentially building social capital to as well mediate some of this. And so when you compare that data, I just, this message of these similarities, I think are just always so striking to me. These are data from the United States, from basically a cohort that was done in Boston with trans youth and cis youth matched on youth and education levels, and as well led by Sarah Reisner. And what he did, again, was just with a simple, using EMRs, looking at burdens of depression, of anxiety, suicide ideation, attempt, and you see across the board higher among trans youth in the United States, or at least in Boston, than you do among cis youth. And when they looked at it, and they quantified it, you basically see about a 4 times burden of mental health issues among trans youth as compared to cis youth. That message of, and here they don't necessarily have the antecedents, but as we'll get to that, these ideas of minority stress really, again, transcend region, they transcend income level. When we looked at trans women specifically in Burkina and Togo, we used a generalized structural equation model to try and understand the relationship between violence, fear, and depression, and more traditional STD and STI outcomes. And so what we had here, about a quarter of our sample basically identified as a gender other than the gender assigned to them at birth. And we were comparing those, both in independent and non-adjusted analyses. You were much more likely to have depressed mood, much more likely to experience verbal harassment, physical abuse, rape, being afraid to seek health care. So again, these are people who've been accrued in an RDS, response-driven sampling study. The only difference here is that they identify as women or they identify as men. And you see these stark differences in a number of really relevant health outcomes. And when we ran, again, this is work led by Shauna, when you run this work, you can see that indeed depression is a mediator here between higher order risk factors like having been raped, verbal harassment, and ultimately fear of engaging in care. And again, these are high burden, both in terms of STDs as well as HIV. And there's a direct relationship between verbal harassment when adjusting for everything else and fear of seeking health care. And so you have this message that indeed depression is really important. It's an extremely important mediator, but it clearly has risk factors itself that all act in this causal pathway to end up with higher, adverse outcomes. So when you now come back to the U.S. and look at this and see how does this play out in the United States, there's a study, basically the Teen Health and Technology study then, is mostly cis youth. I think it's in the order of 18,000 youth that do it between 13 to 18 years of age. In that study, they included about 440 trans youth. So it allowed them to look, again, at a number of comparisons between trans youth and cis youth. And what you see here is that in our first column, my box went away, but in our first column, we have, again, a much higher burden, 40 to 60% higher burden of drinking alcohol, of smoking cigarettes, using marijuana, amongst trans youth as compared to cis youth. But what you see is that if you take bullying into account, and so you adjust for the people's experiences of bullying, most of these associations actually fall away. And you see that about 40 to 60% of the drug use really seems to be accounted for by the verbal harassment and bullying that trans youth are facing. And so again, there's no doubt that there's higher burdens of depression, mental health, but it's also important to keep in mind when we're developing interventions that we have to think about the antecedents for those outcomes. And so and then I just want to talk a little bit about public policy. You know, in Nigeria, some of you may have been aware that in basically the beginning of 2014, there was a new law that was passed there called the Same-Sex Marriage Bill. And what it did was, in a country that had already criminalized same-sex practices, it further criminalized same-sex marriage. But it also criminalized a number of other things, including belonging to any CBO that does service provision for MSM and gay men. It also outlawed research, which is a complicated part of it. It outlawed research. It outlawed, again, service provision. It outlawed membership in groups. It outlawed getting together with more than 5 other people. So no groups bigger than 5, so 4 others than you, to talk about issues related to MSM. So it sort of took it to the next level in terms of, obviously, it went much farther than just marriage. So, you know, during that time, we had this cohort active with University of Maryland, with MHRP, and it allowed us to compare and to see what happens as a result of this law, because often the message we get from government is, don't worry about the law. All the services will keep going. That's the Ministry of Justice. The service provision won't change anything on the ground. And it provided us an opportunity to actually evaluate this. And so these are data that were published in July in the Lancet HIV. And what we were able to do was basically people coming in for our first visit before the law and after the law, we could see clear differences. Again, this is an RDS study where we're accruing into a cohort out of the response-driven sampling. Across the board, we saw higher burdens of fear of seeking health care, avoiding health care. And this was a population, we now have 1,000 men where, again, I showed you prevalence of incidence of 14%, prevalence of 60% of HIV. And so this is a group now more likely to be afraid to seek health care, avoid seeking health care. And when we looked at this in a cumulative fashion as well, you see this increase over time in, again, fear of seeking health care cumulatively. So when we compared, including when we added the person time of people before and after, you still see it's significant people coming for their follow-up visits that they now reported being afraid to seek health care when they didn't before. So it tells you this very clear message that the laws do matter, right? That laws do have individual health outcomes, and sometimes very challenging to measure, including in this study. It's at least a page of limitations, but nonetheless, the message came out that, you know, there is a clear increasing risk of some of these outcomes. So then moving on in terms of engagement in care, right? So this is, you know, the continuum is where at least the HIV world is very focused on right now. And I think the prevention continuums that people have developed also are important. These are data from a global survey that was done by the MSMGF, where they get about 6,100 MSM from around the world, completing this online survey. And there, this is all self-reported data. Interestingly, in this study, you have 57% ever testing, which is its own challenge. But what you actually see is that once people have been diagnosed with HIV, they've been made aware of their diagnosis, they've been deemed eligible for ART, actually the continuum starts looking much better. And that trend kind of continues. In our own studies in Togo and Burkina Faso, here we saw a tremendous amount actually that reported ever being tested. That's in blue here. These are basically 4 cities across these 2 countries in West Africa. And what we saw here actually, and this is an interesting determinant of how these programs were rolled out, is that people were incentivized to test, but they weren't incentivized to see people again to, like, you know, give their status or results of those tests. So actually we saw a really, you know, high burden or a high increase in the amount of people who have been tested. And then, but amongst the people, once they were made aware of their status and were linked into treatment, actually, again, the continuum looks much better. And so these are data. This was supported. This is a CDC-funded study done by Wolfgang Gladek and others in Uganda. And it's a similar message. You know, about 70% of all MSM had been tested. 67% of those who were living with HIV had been tested. But then you again have this massive drop-off of people from the time that they were tested to the time that they're put on treatment. And in terms of there, they actually have viral load data, which is rare. But what they found was that basically 11% of MSM living with HIV were virally suppressed, i.e. 90% are not virally suppressed. But I think this message of that actually the drop-off between once they're in ART and viral suppression is pretty minimal. It's actually pretty good. And when we look at Patrick Sullivan, Eli Rosenberg and Patrick Sullivan's modeling data from the U.S. published in the Lancet HIV last year from the U.S., it kind of looks similar. right, that you have the total number of people living with HIV, about 60 to 70% have been tested. And that's where you have your massive drop-off. It's that linkage step of that getting them on treatment is where the most drop-off happens. And then after that, it's pretty good. They're losing about 20% per step, which isn't perfect, but it's not bad. But the major drop-off, you know, although it's more stark among African-American MSM, but it's the same among the most drop-off happens between their diagnosis and the retention linkage and treatment. And, you know, what's interesting is, and this is data from our cohort, and basically we're looking at a survival analysis of engagement and retention in care from 0 days to 500 days. And our most successful one, where we had the least loss of follow-up over the first 500 days of follow-up, so about a year and a quarter, was when we had engaged people in treatment as prevention. And where we had our most loss to follow-up, basically 75% of our sample, was where we were just trying to keep people in follow-up, but they didn't engage in treatment. And so what the message from this tells us is that treatment itself is an important tool of retention for other services, like STI management and mental health services and all the other things that people need. And that the treatment actually serves as its own retention tool, which I think is important as we're moving forward with scales of treatment. So just two quick models, but there's a lot of data, but two quick models just to share, and just in terms of what we think could be the potential benefit of different interventions. This is work that we're doing under Sibanye Health with Patrick. Ron Brookmeyer at UCLA did the mathematical modeling. The two groups in South Africa are the Desmond Tutu HIV Foundation at the University of Cape Town and the Human Sciences Research Council, the HSRC. And so we basically used an agent-based model to look at projecting 5 years forward. If we scaled up different interventions, how would we do? And we specifically wanted to look at was PrEP. You know, this was a couple years ago. PrEP was, this was just as IPREX was coming out. So we wanted to look at PrEP. We wanted to look at scale-up of treatment and other prevention measures in terms of changing condomless sex, sexual practices, and engaging in HIV testing. And so just starting here with our red line near the bottom, what we see here is basically the percentage of people tested who are on treatment going from 0 to 100%. And what you can see is that it's actually relatively modest, that if we scale up treatment, now this is when their treatment cutoffs are 350, worth 350. And in a place like South Africa where they initiate 600,000 people a year on HIV treatment, you know, they're sort of dealing with the scale up of that they can. So they're working to get to 500 and beyond. But nonetheless, it's just a huge amount of people that they're dealing with. But what you can see is that actually if you engage, you know, just treatment on its own in the absence of changing anything else, it's a relatively modest decrease, about 5 to 6% new infections over the year. If you add PrEP uptake about 50%, which is about what they saw in PrEP OLE, the open label extension in the South Africa site, about 50% were interested in staying on PrEP after they knew what they were taking. It goes up to about 10%. And what's interesting is that actually it's really the change in condomless sex that it seems to have actually a major, you know, a major bump on this. And so you see this real synergy between what we know to be important behavioral interventions, changing condomless sex and increasing, or I should say decreasing condomless sex, increasing use of condoms and condom-compatible lubricants. And then you see that synergy where you can get up to over 30%. And when we add testing in there, because testing uptake is just still really limited, we get another bump in there to about 35%. And so what this, again, from the perspective of MSM in South Africa, it tells us about the synergy that, you know, PrEP on its own is a wonderful intervention. In the absence of changing condomless sex, in the absence of changing testing, is going to have limited benefit because we won't know who's candidate for PrEP. Similarly, we won't know who's a candidate for treatment. And another challenge to keep in mind when it comes to PrEP is that when we look at people using the high-risk index scoring system, when we look at those who are appropriate candidates for PrEP, we see about 20% prevalence of gonorrhea and chlamydia. And obviously, PrEP programs as they're currently developed are not, at least in low middle income settings, are not including effective STI management as part of their PrEP program. And so, you know, and actually, when we go down here, we see that basically 30% of the people that were in high risk were avoiding care when they had STI symptoms, even though they're candidates for PrEP. So again, it tells us this message that PrEP, obviously in a vacuum, can come with these other challenges that we may not have otherwise considered. similarly, when we looked at the incidence rate, these are correct numbers, by the way. Amongst our people living with HIV, we had 40% incidence of either rectal gonorrhea and chlamydia in this cohort. And similarly, what the message here is that we've been running a treatment program, and treatment prevention programs are engaging people, and that's important, but they're not doing effective STI management, and we're seeing incidence rates of 40% of gonorrhea and chlamydia. So again, it tells us that, basically the treatment world and the STI world need to work hand in hand, or at least these interventions need to be comprehensive as they're actually implemented in order to be beneficial. The very last piece I'll talk about is around what we know around prevention interventions for trans women. The sort of overarching message of this is that there's a real disconnect between the amount of investment in trans research compared to the burden of HIV amongst trans women. So that is just that clear, whether we're looking at NIH-funded studies, there's a couple more that have started in the last year, but there's really like a handful of studies that are dedicated for trans people around the world. So, when we looked at, the only way we can really look at the benefit here is to really look at mathematical models. This is a mathematical model that was done by Tanya Poteet and folks at Imperial College. So Tanya at the time was at OGAC. She's now back with us at Johns Hopkins. But they want to ask the question, could they achieve a 50% decline in new infections among trans female sex workers over a 10-year period in Lima and San Francisco? And they picked those two cities because they're different, but also they're basically the only cities around the world where they had enough data to really parameterize these models in a way that was meaningful. They tried to do a few others, and they just didn't work out. And they looked at 5 different interventions. And so the first question was, can they increase condom use with stable partners? PrEP was obviously something they looked at. Early treatment for folks, at that time they looked at 500. Basically changing or decreasing the amount of transactional sex events or compensated sexual events among sex workers. And then finally increasing condom use with clients. And I think, the message is clear that when you look at these interventions, here in red you have their 50% threshold. What you can see is that each of the interventions in and of themselves, I think as we could expect, are not going to do it. And you really need these combinations of packages to get you to that 50% decline. And in Lima, given the sort of low coverage of existing services, they saw an over 70% decline in infections over 10 years. In San Francisco, it was only where they had all 5 working together in synergy where they saw that. And again, that's related to the fact that there's just a higher baseline coverage of services already in San Francisco, which just means they have to do that much more to really see those sort of declines. So then just some closing thoughts. One is that there's just this clear data paradox, right? That, we know the least in the places that have the most stigma, but the message hopefully that comes across here is that whether you're looking at the U.S. or Sub-Saharan Africa, and even across places in Sub-Saharan Africa, you see a lot of similarities because at the end of the day, it's biology. And so, the determinants are more similar definitely than they are different. You see a really high incidence among young people. You see higher burdens among trans women as compared to other gay men and other MSM across a number of health outcomes. And, so this comprehensive research agenda really has to, obviously, we have to look at content issues in terms of what we're going to be doing, what appropriate scale is, how we're going to implement them appropriately, and then obviously prevention and treatment programs. I think the world has moved now to deciding one or the other, and clearly the message is there has to be both for both MSM and trans women. So just in terms of acknowledgments, I really, the people who participate in these studies do so. I'm always shocked that people continue to participate, like people want to come in and people engage, but they do so at very low personal benefit and I think significant risk. Similarly, the community groups that we work with in all these different settings also do so with little benefit and a huge amount of risk. I want to thank a number of people who contributed to this and as well the TPOX program at Hopkins. Thank you. There was a lot of data.
Hi, I'm Bill Pearson. I'm from the Division of STD Prevention here at CDC. It was a great presentation. What I found most interesting about your presentation was the discussion on stigma and depression among transgender So I'm wondering, with your studies in sub-Saharan Africa, and specifically Nigeria, which I have a little bit of background in, are you seeing any difference based on religious prevalence? Specifically with Nigeria, it's mostly Islam in the north, Christianity to the south, and your two study sites were Lagos and Abuja.
Yeah. So this comes into the data paradox message. I'll say a few things. One, we basically can't go much further north than Abuja and do these studies. It's just, there's, I mean, we're starting to, but I mean, there's a number of issues going on in terms of actual, safety issues that are ongoing in the north, irrespective of gay men's health, even bombings in Abuja, as you know about. So, the reality is that there's been very limited work up there, but you meet people that migrate down to Abuja, to Lagos, and you'll ask them in qualitative work around dynamics in Jos and other places further up. And it's clear there are smaller networks of gay men. There are venues that they're going to. There's no services. But there's likely transmission, and the incidence is likely high. We just don't know. We should say we haven't measured it, and I don't know that we'll be able to in the near future. And the other, I'd say the other element about stigma is that, one of the things, and this is, we've talked to Gabrielle about this also, it's just like, how are we, the issues around measurement of stigma, that we really, we've worked, and Shauna, who's here, we spent a lot of time trying to think about how are, if we want to engage in stigma interventions, which everybody, I think, agrees upon is important, how do you measure those? How do you, what does a stigma intervention mean? What are sort of standards in stigma interventions? I think there's a lot of work that's happening in that area, and a lot of it has been qualitative. We're trying to think about, especially around interventions, and especially around funders like OGAC and the Global Fund and others want quantitative outcomes related to their work, and so we're really trying to think about metrics. But there's two pieces. One, we need to improve the metrics so that when we can get to the point of doing these studies and doing these interventions that we're measuring the right determinants. And secondly, this is just that issue that we're facing. And even, there's other countries you keep going north of Nigeria, although in Niger, like in Niamey, there's huge parties with gay men that are going on and just no work. And so it's like, it's an issue about the government doesn't want to engage in it, or it's a safety issue. And so the way we work, it's very much with government. And so we really have to try to work with them in order for them to see the value in this. But yeah.
That was great. Thanks. This is Kyle Bernstein from the Division of STD Prevention. I was glad to see you talk a lot about defining trans populations and the use of the sex, gender assigned at birth and current gender as opposed to self-identification of trans. And before I came to CDC, I worked in the San Francisco Department of Public Health, and we tried to implement the two-question measurement in our STD clinic. And I was really surprised to see how much pushback there was both from staff and from clients. And this is the San Francisco Public Health STD Clinic. So I'm curious as to how the implementation of that operationalization has worked in some of these settings that you work in.
Yeah, so I think one of the things I'll say is that in this systematic review that we did, we had 116 papers and 95 different definitions of trans within those definitions. So a large part of our recommendations are on definitional consistencies, obviously for surveillance recommendations. I think that, we haven't, I'd say, every country is distinct. And I'd say that, and so Sean and I spent a fair amount of time talking about, I'll say this. In the early days, we asked people if they're trans, and literally nobody said yes. And so, so there was an assumption really there were, 10 years ago, that's what we would ask, when we make the same mistake as many others, like, are you gay, bisexual, trans, and so, and you get very few people obviously saying that they're trans, maybe one person. And so when we separated it out, now we ask, are you trans, are you intersex? And I think there's a tremendous amount of confusion. We ask trans, intersex, or do you identify as a female, as a male, et cetera? And I think there's a tremendous amount of confusion and overlap between, are we talking about sexual practices? Are we talking like people are bottoming, so they're women? Are we talking about, how are they identifying gender? And I just think that what it means is, for us, it means that we need to do a lot of groundwork to really understand these data. I think the only message, if I had more time just to talk about trans, I would say that all we have so far are signals, and we know that there's something there, and we want to try to identify it because we don't think that sort of male-oriented interventions are going to be beneficial for them. And so that's something that I think we're just thinking about. Right now, all we really have are signals. And I think people have done more nuanced work. I've talked to Joanne about this. They've had some issues with this. I didn't show Sari's data. Sari Reisner has really nice data together with Matthew Mimiaga and others from Peru, where they also have a really complex algorithm for how people identify. And I think and then the message, when I'm in Sub-Saharan Africa, all I say is that gender is complicated, and it's complicated everywhere. It's no simpler across Sub-Saharan Africa than it is anywhere else. And people often talk about complex genders in Asia, and that it's more binary in Africa, and it's just not the case. But I just say that we just don't know that much.
Thank you for that talk, Steph. That was great, and lots of great ideas that I think will be helpful for the work that we do here at CDC. I have a question about structural interventions and what has been formally evaluated, because just thinking about inequalities and how to affect them, there's so many things that can be done and probably so hard to measure. And I'm aware about interventions among female sex workers in India that have shown that structural interventions actually affect behaviors, but has there been similar work done for MSM?
Yeah. So, I think, the U.S., there's been a lot. I'll talk about sort of outside of the U.S. setting. I think that we did a stigma review that we published in JIS. There was a special issue on stigma about a year and a half ago, and we did this systematic review of stigma interventions that we put in there, that we did together with ICRW. And I think one of the trends there was that there really was no consistency of the interventions that were being done or the measurements that were being used to evaluate them, which then on the back end, it makes it really hard to then try and say some really clear things in response to that, like the evidence overwhelmingly is this or that. And if you ever try to apply something like GRADE or any of these systems to it, you would recommend against all stigma interventions. You would say we stop doing them altogether, And so I would say that, even amongst the Sonagachi data that as part of the ABHAN program from India, it's observational. There's no there's no trial data to support any of these things. And so, that's kind of the world in which we're living. We have some implementation science awards from USAID that we're trying to look at stigma interventions and seeing how we can, what I showed earlier around the building social capital is kind of like I don't think we're going to change society, and I'm definitely not the person to change society. Or at least it's not going to happen in the sort of time frame in which you could measure an outcome as part of any sort of study. But maybe there's ways of intervening in terms of building social capital to be more resistant to stigma, for example, external stigma. Maybe there are some ways of addressing healthcare-related stigma that at least make it such that people can engage healthcare in safe and effective ways, and then sort of try and break that pathway. Addressing depression maybe as an intermediary about better mental health counseling. So I think there's ideas of things that we want to do. People have done stuff like there's media programming and media content analysis and all kinds of things I didn't talk about today that people have done, but it's all observational, pre-post. And really, for this sort of crowd, it's weak data. But you have to kind of dig deep to try and think about who's actually going to fund it, because there's a real the NIH doesn't think it's science, to fund these sorts of programs, and others think it's sort of off in a different perspective outside of health. So it's a really tough area to be in.
Stefan Baral from Division of HIV. Great talk, thank you. I have a question. I thought it was very interesting when you presented the data about sort of a lot of people get tested, but then once people get it sort of seems like well, I think the common sense conclusion is, well, if we just link people to care, everything will be fine. But I'm wondering to what extent is that just, those people have no other incentive than they want to be there. So you have the people who want to be there. And I was especially interested in that graph you showed where, you said, oh, well, we incentivize testing. So everyone gets tested, and then it falls off the cliff. So if we incentivize linkage, would linkage go up, and then if it fell off the cliff, that's the next step, and the data supports that, or would people stay in, and how do we test that?
I mean, I'd say a few things. One is that, you know, a lot of the treatment interventions are relatively, at least at scale, are much newer. You know, I mean, the prevention interventions, if you look at, let's say, HPCN, the HIV Prevention Trials Network, a lot of their prevention interventions have been done over a number of years, and they're just starting to do their treatment interventions. And a lot of them aren't working very well. Like, if you guys saw the results for HPCN 065, it was a conditional cash transfer program in New York City, and I'd say there's a few sites. And I'd say, you know, they framed it as a positive outcome. Overall, it didn't really work, right? But the only one part that did work was retention of MSM Living with HIV in New York. The conditional cash transfer program worked. So, you know, I'm not here to sort of sell conditional cash transfer. I mean, but and you know, there's obviously clear questions around sustainability of that. But I would just say that it's a new science, which is why right now the retention is mostly because most of the people who are linked in are people who are really sick. You know, in a lot of these settings, these are people, you know, the average CD4 diagnosis in most places where I work is about 100 or 120, 150. And so these are people who are symptomatic, and that's once they're retained, they feel better, and we believe, and I think many do, that once you start really getting at higher CD4s and getting at people who are asymptomatic as part of these sort of universal coverage of treatment studies, we're going to have much more lost follow-up. And I think we all are going to have to think about collectively how to better deal with that. Is it a cash transfer program? Is there other ways of engaging people in care? Are there other services that we can provide to sell people on treatment? And again, it's kind of like diabetes at this point. These are people who have never had symptoms of their HIV other than some doc or nurse telling them that they have HIV. So I just think it's going to be a real challenge over the next number of years as people focus on treatment. Sure. Yeah, any questions via the internet?
Hello, operator?
Yes, to ask a question, please press star, then 1, and record your first and last name. To withdraw your request, please press star, then 2. Once again, to ask a question, press star, then 1. At this time, I'm showing no questions.
Right. Nope. No, pleasure. Yeah. No, thank you.
Thank you all very much. 1:30 till 3 is the panel discussion. Enjoy your lunch.
Thank you for joining today's conference. That does conclude the call at this time. All participants may disconnect.